Thank you to Mauro, Rive, and Anton for inviting me to tackle this challenging question. So I'm going to start straight away with the difficult one. What does oral PrEP evidence mean for post-exposure prophylaxis, PEP? So firstly, a reminder about the evidence that we've got for oral PrEP. We've got 6 randomized controlled trials of TDF-FTC. 3 of those were conducted in men who have sex with men and transgender women. IPREX and EPIG-A had a placebo control, and PROUD was an immediate deferred design. We've got 2 in heterosexual populations, both placebo-controlled, Partners PrEP and CDC Botswana. And then we have an RCT of tenofovir compared to placebo in people who inject drugs, CDC Thailand. We've got an RCT of TAF-FTC in men who have sex with men and transgender women, and this one was a non-inferiority design compared to TDF-FTC, Discover. And there's 1 trial underway of TAF-FTC compared to TDF-FTC in heterosexual populations, mainly female, PrEP. So that's a lot of RCTs. What about post-exposure prophylaxis? Well, we've had no randomized control trials of efficacy. We do have occupational exposure cohorts, and we have a series of elegant animal challenge experiments. So it's really expert opinion that guides us to advise 28 days, usually triple therapy with a backbone and an integrase or protease inhibitor. But some guidelines do allow 28 days of the backbone alone, typically TDF-FTC. Post-exposure prophylaxis can be started up to 72 hours after exposure, but we do know that intracellular replication is estimated to start within 12 hours of sex, and actually the cycle is completed within 1 to 2 days. So lots of virions out to infect the next generation of cells. So circling back now to what we learned from the EPIG-A study, the on-demand regimen, the instructions were to take a double dose 2 to 24 hours before sex, and then follow that by a single dose 24 and 48 hours later. They looked at adherence in CASI, 1,212 sex acts in 319 participants, and correct use was defined as at least 1 pill before and 1 pill after sex. And you'll see here in that table that Jean-Michel presented, in 2015, 43%, only 43%, so modest correct use of this regimen. 29% suboptimal, so they'd only taken a pill either before or after, and 28% no PrEP at all. But in spite of this, modest ability to adhere to the instructions, it was highly biologically effective with an 86% reduction in HIV. So clearly the pill around the sex act is critical. You take those data combined with the Prevenir, the open label extension that followed, all of the clinical effectiveness data together with what we know about viral transmission, there's still a lot we don't know about that, and the pharmacokinetics of the drugs, and bearing in mind that PrEP users will have a PEP regimen at home, surely the sensible thing to do after a significant risk when there's no drug on board, so no drugs being taken for 7 days or more, is to take a double dose as soon as possible after the event, followed by daily, and then get an HIV test and advice as soon as possible, rather than waiting to get to clinic and AE, which may take a while. So moving on to new strategies, and we do have a lot of those, I guess really it's not just new strategies, it's new drugs, because we've got 2 randomized controlled trials. These were conducted in the placebo era, Dapivirine Ring, a monthly Dapivirine Ring compared to placebo in young women, the Aspire and the Ring study. And then there's 2 randomized controlled trials conducted now in an era where there has to be an active comparator. So compared to TDF-FTC, 1 in men who have sex with men and transgender women, and 1 in young women. So a little bit more about the Dapivirine Ring here and what we learned from the open label extension, the HOPE study. The key messages really were that women did actually in general want to continue to use the ring. 73% of them collected it at every visit. And of those returned rings, 89% have PK data that supported use in the previous month. So good adherence amongst those who took up the rings. So it was noted that the Dapivirine released significantly was significantly higher than they'd seen in the placebo-controlled trials. But in spite of this, you'll see there at the bottom, the reduction here in the counterfactual was still only modest at 39%. So not as high as we had seen in the oral PrEP studies. Nonetheless, the European Medicines Agency approved the monthly 25 milligram Dapivirine ring. It's been recommended by WHO as a choice to offer. And the horizon looks like 3 monthly rings. And of course, it's now open to multi-purpose rings, which could be a very attractive choice for women. So what does this mean in practice for us? Well, it is, yes, of course, a lower biologically efficacy. It's very important that women understand that. But nonetheless, they may prefer the ring for a number of reasons. It's discreet, low levels of systemic drug. Not everyone likes a lot of drug in their system. And it's user control. The drug's gone shortly after you remove the ring. So the REACH study, which was presented at CROI this year, the choice period of the REACH study, when women were offered a choice between the ring or oral PrEP, having experienced both of them in a randomized crossover phase, 67% actually chose the ring. These were young women, 31% oral PrEP and 2% declined. The International Partnership for Microbicides, I know, will be very happy to work with providers to facilitate ongoing use in Europe or the US if a woman would like to do that. So long-acting cabotegravir, 2 exciting results, the HPTN 083 and 084 trials. Both of these were showed that LA-CAB was superior to oral PrEP in terms of efficacy. The participants were carefully selected from populations where it was recognized they struggled to adhere to daily or oral tablets. Adverse events were actually very common, but they were very similar in both groups. And the only thing that was significantly more common in the LA-CAB group were the injection site reactions, which is not really a surprise. Nobody discontinued injections because of an injection site reaction, though. This is clearly going to fill a really important gap for people who struggle to take tablets for a range of reasons. So just to remind you of the details, an HPTN 083, this is the first one here, wasn't set up to show superiority, but with 13 infections in the LA-CAB group and 39 in the TDF-FTC group, it did indeed show superiority. In 084, the infections in the CAB group were even lower, with only 4 and 36 in the TDF-FTC group. So really pretty outstanding result for an active comparator with a drug that already is excellent. 083, also I meant to put the New England Journal reference on this slide. 083, the safety here, I thought it might be useful to just show you this. If you scan across the table, you see it's really very similar in all the groups for severe and worse events, serious adverse events, etc. And the events of special interest, the seizure and liver-related issues leading to discontinuation, also very similar. Looking in detail at the events, I noticed only 2 things that looked a little bit different. Pyrexia was more common in cabotegravir, that is described in the product characteristics, and an increased blood glucose. Not sure I can explain that, but hopefully somebody can in the discussion, and it may of course not be real, but just chance. So FDA agreed to fast track their review, which is fantastic. FDA approval is absolutely key to mobilizing US donor investment. And that in turn is absolutely key to delivering PrEP to low-income countries who depend on it for distribution. So we expected an approval this year, early this year, but actually we got it at the back end of last year, December 2021. So great news. So I've been thinking about what LA cabotegravir would mean in practice. Definitely we can anticipate preferences amongst people that struggle with tablets. We should anticipate that. In the trials, that tended to be women, particularly young women, adolescents and young men who have sex with men, particularly if they don't identify as gay. And of course, societies where there's a high level of discrimination, and that's not easy to identify as gay. But in my setting, at least in high-income settings, it's going to be on patent. So cost is likely to be a barrier to routine commissioning, routine programming in many regions. And the need for viral load diagnostics, because LACAB is extremely good at suppressing viral load, thereby potentially delaying the antibody response, will of course add to the cost, as well as the need for more frequent visits than you'd have in an oral PrEP program. So it'd be 2 monthly visits, not 3 monthly. Nonetheless, I think there will be definitely circumstances when clinicians will choose to use LACAB because TAF and TDF are contraindicated. If you imagine very low renal clearance, low EGFR, then this would be a potential option. And I am aware, because we have made use of it, that ViiV has a compassionate release program in Europe, I imagine also in the US. So really wrapping up now with the really new drugs for prevention, and there are 2 of those to tell you about. One of them is Dapivirine. This is Merck's drug, FDA. It's potent, long-acting. It protects in SHIV challenge and very good levels of drug. 2 trials in Power 022 and 044 have started in women and adolescent girls at high risk of HIV, sub-Saharan Africa, and men and transgender women having sex with other men at high risk of HIV. This is an active comparator to FTC-TDF or FTC-TAF. And those trials, they're paused at the moment because of an observation in the treatment trials that is yet to be explained and is being investigated. The other drug is lenacapavir. It's very potent against 3B, suppresses virus in clinical trials in people with HIV, and a single subcutaneous dose of 900 milligrams leads to very good concentrations for a period of 26 weeks. Purpose 1 and Purpose 2 both started again in these 2 diverse populations, cisgender women in South Africa, and then men, transgender men and women and gender non-binary age 16 and over in Puerto Rico and the US. And these trials, actually, I think Purpose 1 probably was started live as an FTAF compared to FTDF, but then lenacapavir has been added in there. And for Purpose 2, it's just compared to FTDF. These trials are paused at the moment because they've got to sort out an issue with the vials around the sort of, I'm not quite sure exactly what the issue is, but it's the vials, it's not the drug. And I think these trials will resume shortly. So in conclusion, we have an exciting pipeline of drugs and strategies for PrEP without a doubt, and we do know that choice will help with adherence in the future. But we really, really do need to sort out post-exposure prophylaxis, at the very least, to inform people who are on pre-exposure prophylaxis, who've got drug at home, how they should use it if they've not taken any tablets for 7 or more days and they have an event that is a significant risk. So I look forward to discussing that more with you, and I thank you for listening to me.